Hello everyone and welcome. My name is Sanya Fitzgerald. I'm from Switzerland, Geneva, and I work as an independent market access consultant. I'm also a technical officer for the Rare Disease Interest Group. I've been the HTAi member since last year, and I'm here to introduce the Plenary 2 NextGen methods, hype or here to stay. Enjoy!
All right. Muy buenos días y bienvenidos. Good morning and welcome. I'm very excited to introduce Plenary 2, NextGen methods, hype or here to stay. So I am Marina Richardson. I will be co-moderating with Federico. Wim will be the challenger, and then we have an amazing 3 panelists here. So you'll hear more about what we mean by challenger as we get going here. But those are who you will be hearing from today. But we'd also encourage a lot of audience participation. So have your phones out, enter Slido for polling and questions. And we will also invite you to the mic at any point to ask questions as well. Okay, so we're a global community, global methods, lots that we could choose from. I think there's an unlimited number of methods that we could explore today. And we've selected 3 that we're going to focus on today. So environmental sustainability, adaptive HTAi, artificial intelligence, and real-world evidence. These will be the 3 that we're going to be focusing on from our panelists. And I think important to keep in mind that yesterday we heard in Plenary 1 that HTAi could be challenged with taking more of a system shaping role. Or, I mean, I think we are just with our current remit also facing challenges with gene therapies, rare diseases. So regardless of which direction HTAi takes, it will be important for us to have rigorous methods to take us there. So we're going to debate methods, the 3 that I highlighted on the previous slide that I would argue are at their peak of inflated expectations. So lots of hype, not necessarily part of mainstream. So as we get into these methods, I really encourage us to think about which direction they're going to take over the next 2, 5, 10 years. Will they reach that peak of inflated expectations only to fall into a trough of disillusionment and become a one-hit wonder? Will they reach that peak of inflated expectations, hit a slope of enlightenment, really to just resurface 20 years later as a new fashion trend? Or will they really become part of mainstream and enter this plateau of productivity where we'll see incremental innovations over time, like a mobile phone and the evolution that we've seen there? So we're going to hear from our 3 panelists, and it's going to be structured. They're going to try to convince us that their method is really here to stay. And we're going to hear about the need for the method, the rigor, and the state of the implementability. So they're going to try to convince us. You as the audience are going to be the judge.
Hola, buenos días. Welcome everybody. Federico Gustowski from the host institution. Well, inspired by the sustained HTAi work, we are going to facilitate this discussion using this framework that Marina told about need, rigor, and implementability. We really encourage you to do 2 things. One, to ask questions in the app of the event, and also you have to judge which is your overall rating of each one of these 3 methods along the way. Along each one presenters, you will have to answer 1 rating scale. So how do you judge from 1 to 10 each one of these methods that are being presented today? Wim, as Marina said, will be the challenger, that with the help of the audience will ask questions to understand what is at the heart of each method that each speaker will represent. probe for specific examples of practical application of the method and seek clarity on what might help or hinder the adoption of HTAi bodies. So, without further ado, I will present our 3 champions of these 3 methods that we're gonna hear in each one of the sessions. The sessions are, it's a 10-minute session presentation of each speaker and then a 10-minute challenge and interaction that Wim will lead. We have here today Melissa Pegg that will champion environmental sustainability. She's a senior researcher and consultant in environmental sustainability in HTAi at York Health Economic Consortium and the University of York, United Kingdom. She's also the chair of HTAi Environmental Sustainability Working Group and an advisory member of the NICE HTAi lab in this discipline as well. Then we're going to have from India Shitanshu Shekhar Kar, who will champion adaptive HTAi. He's currently the professor of preventive and social medicine at Jawaharlal Institute of Postgraduate Medical Education and Research in Pucheri, and officer in charge of Jimper International School of Public Health. He's also a the head of community medicine from Primber and a Fulbright Nehru Academic Professional Excellent Fellow at USC, Global Health Institute in LA. And finally, we will have Cyril Sek, who will champion AI and RWE, real-world evidence. Cyril is a strategy and policy advisor with expertise in strategic planning, organizational design, and implementation. As digital strategy advisor of Africa CDC, he led the development of the organization's first digital transformation strategy. His work focuses on strengthening country capacity and collaboration to improve access, quality, and efficiency in healthcare. This includes advancing country capacity in HTAi to inform investments and enable the sustainable adoption of digital health innovations. And last but not least, our challenger, Wim Getsch, whom most of you or many of you may know. Wim is currently at the board of directors of HTAi, and he's the chair of this annual scientific meeting committee. He's also a professor of HTAi and pharmaceuticals at Utrecht University, the Netherlands, and the coordinator of a large ongoing Horizon Europe project, Sustain HTAi. So please welcome everybody to the floor, and we invite Melissa to give her elevator pitch, or not so much elevator.
Thank you, Federico. Oh my goodness me, it's an absolute pleasure and an honor to be standing in front of you today. Thank you for joining us for this plenary. I look forward to the discussions. So the carbon clock indicates that humanity has less than 5 years to address the planetary health crisis to prevent rising above 1.5 degrees C, the threshold. Crossing this boundary would lead to irreversible climate change and tipping points. Many HTAi organizations and agencies are recognizing the contribution of healthcare's environmental impact. Countries including Canada, Switzerland, the UK, and other countries and organizations such as ISPO and HTAi are positioning themselves in terms of developing approaches and potential methods and frameworks in order to incorporate environmental sustainability in HTAi. So you may have heard of the planetary boundaries. There's 9 of them, and we've crossed 6 already. The novel entities boundary is at a point, a critical threshold, and it's the pollution that we're causing, the anthropogenic pollution, the greenhouse gases, the plastics, the chemicals, pharmaceuticals that are contributing to this. So we must be careful that we don't oversimplify the methods that we're developing and that we're so good at in HTAi that might have the opposite effect of what we're trying to achieve. For example, we might end up going down the rabbit hole of a narrow scope of carbon emissions only. And we have approaches now that Tulin et al. In 2023 have suggested: the information conduit, the parallel assessment, the integrated assessment, and the environmentally focused assessment. So there really is a lot that we can start doing now without having the frameworks in place, being pragmatic and practical in our approach. By 2050, climate change is expected to add $1.1 trillion in extra costs to the healthcare system globally and contribute to over 2 billion healthy life years lost. Surely we cannot ignore that we need to incorporate human health impact of the decision-making in healthcare attributed to environmental breakdown. Negative externalities could be included in the economic evaluation, something I'll chat about on the next slide. And universal health coverage cannot survive without sustainable development. Sustainability is defined by the consideration and the balance of the economic, social, and environmental pillars, the 3 pillars. Value-based procurement, sustainable quality improvement framework by the Centre for Sustainable Healthcare in Oxford in the UK, for example. What an excellent framework, what an excellent opportunity to include environmental sustainability in the value-based procurement frameworks. There's so many co-benefits that can be realised that don't compromise patient safety and outcomes. So what is the scientific robustness and methodological grounding? We know the environmental impact of health technologies. There are hundreds of papers out there to say the environmental impact of health technologies is significant. We have evidence for some more than others. There tends to be more evidence for medical devices than pharmaceuticals at the moment, for example. And at present, there's no overall agreement, although as a community, as a wonderful community in this room, and globally, I'm quite new to HTAi, really. I've only been doing it for a few years, but I worked in industry for 18 years before this. I feel so passionate about environmental sustainability, as I'm sure most of you in this room do as well. So together, we're taking approaches such as, for example, Canada undertook an environmental horizon scan a couple of years ago, really practical way to prioritize where we could focus now on supporting healthcare to reduce its environmental impact. Let's do more environmental horizon scans to look at what health technologies we need to prioritize. Where's the big ticket items? And how does environmental sustainability weigh in comparison to other HTAi domains? Again, I go back to the sustainable quality improvement framework, the prevention, the low carbon alternatives, patient outcomes, patient experience. All of these factors are considered when you can incorporate environmental considerations within the sustainable quality improvement framework. Where in a cost-effectiveness analysis, for example, might we see the environmental cost? Could it be included on the clinical side as a disability-adjusted life year, for example, or perhaps on the cost side as a societal cost of carbon? And we know there's limitations to that model. Or perhaps both. The environmental costs could be on both sides. And we could also look to our colleagues in environmental management for the frameworks that are very well established already, and the development of newer frameworks, really exciting frameworks where we have that multi-stakeholder collaboration with industry and other stakeholder groups in the development of the ISO PAS 2060. So implementability, how practical or adaptable are environmental sustainability methods for health systems? Climate change is a universal issue. We can take steps forwards, practical steps now. We are so good at being able to take the data we have and be transparent and reproducible in our reports. Let's do the same with environmental data. Let's create that framework, that backbone for life cycle assessment of broader environmental outcomes, not just carbon dioxide equivalent, but human health impact, loss of biodiversity. Climate change is a big problem, but the bigger problem is biosphere integrity, which is loss of animals, loss of the biosphere. And so we cannot survive without the biosphere. We need that to be looked after to really be able to achieve planetary health. So we can quantify that. There is advanced life cycle assessment software where you can quantify the loss of biodiversity, the human health impact, and resource use. Let's start to use advanced software to generate environmental data that takes into consideration global modeling. There is no boundaries to climate change. And we can also utilize HTAi tools such as value-based procurement, guidance, appraisals, technology prioritization lists, decision aids. Let's make sure that we engage with patients, patient experts. How can we develop sustainability which reduces environmental impact, takes into financial considerations and social as well? And then early HTAi opportunities. That's a really fantastic opportunity to spearhead environmental sustainability, is at that early HTAi stage. Thank you very much.
Well, thank you, Melissa, for this very interesting and exciting presentation. Before I'm going to challenge you, I would also like to ask the audience to come up with questions, because we want to use those 10 minutes to really get input from you on how you actually perceive the need, the rigor, and the implementation of environmental issues in HTAi. But I'm here to challenge you, and I have an example. So within my project, Sustain HTAi, we also talk about implementation of HTAi methods. And we had a meeting quite recently in Budapest on what should we invest in this? And we were actually seriously challenged by countries, for instance, from Central and Eastern Europe, say, well, we are really already struggling with our resources, with our costs. So this is much more important than taking another factor into account. And I think I perceive it a little bit as well, this whole environmental thing might be a little bit like a first world problem. And it's not that relevant for countries which have different issues to address. So what would your idea, Melissa, to really indicate that also for those countries, it's important that we're going to take environmental issues into account?
Thank you, Wim. It's an excellent question. My question is, how is environmental sustainability being perceived by these various stakeholders? I've already described to you that value-based procurement might look like the sustainable quality improvement framework. So we're looking at those health technologies that can support prevention, low carbon alternatives, create a leaner pathway, and empower patients. So it's not always about looking to quantify the environmental impact across the whole life cycle. We don't need to do that to start to reduce the environmental impact. I think if we can apply a framework and even include some qualitative data and start there, it's a good starting point. It's what's being done by other countries. I've seen reports recently by NICE and CDA where they've included qualitative aspects to look to start to approaching how you would deliberate perhaps environmental data against financial and social criteria and patient outcomes. And also, I'm a huge fan of waste. So for my first master's, when I was studying sustainability, I rummaged through some waste bins in the operating room, And so for me, if we can start there and look at what we're wasting to then become more resourceful, it's almost looking at reducing environmental impact from a different sort of lens, where if we can even report within HTAi the levels of waste being produced by the comparative health technologies, that for me is a good starting point, because we already, if we know how much waste is being produced per year by using a particular health technology for a specific indication, then we can already attribute greenhouse gas emissions, waste volumes, and other types of environmental impact data associated with those waste volumes. Thanks, Wim.
Thank you, Ms. Lissa. I already looked to the questions which I've brought up by the audience. And I think that is, well, we're talking about frameworks, but do we already have examples on where actually environmental issues are being taken into account when doing an HTA? And I would also link another question to that. So what would be your approach? I think you seem to suggest that there might be options to actually include it in the quality measurement. But alternatively, you could also say, well, that's probably still too hard because we don't have all the data. There are a lot of assumptions over there. An alternative might be to just take it in consideration as an additional factor during the appraisal. So what is your approach to that?
I think this is a very sensible approach. I have a very visual mind, and when I think of HTAi, I think of a book and all the chapters in it. Yeah. And one of the chapters needs to be environmental sustainability with the backbone of a life cycle assessment. We might not have all the answers at the moment, and we can say we don't have all the answers because that's what HTAi is good at, is being transparent. So I think the suggestion of including it as an additional factor that is able to be deliberated in addition to the consideration of the cost effectiveness analysis by experts, and bringing in environmental management expertise into the assessment group is certainly a great approach, especially to ensure that we can start to work on it now.
Yeah, clear. So another question which comes up, and also in line with another question I have, is what are the minimum environmental aspects to take into account? And just to give you an example, also a few weeks ago, our Dutch agency produced a guideline on how to include environmental aspects. And they suggested to start with carbon emissions. And they said, well, we can do it all, but probably on carbon emissions we have the most information. So that would be a right starting point. So what is your thought about that approach? Or would you say, well, we should start with something different, or we should be more comprehensive from the beginning?
I think it's very wise to start with greenhouse gas emissions because climate change is considered a core planetary boundary. It creates 3/4 of anthropogenic greenhouse gas emissions, CO2. So starting there is very wise. It's standardized metric. If we're able to report it in CO2e, then you're incorporating all the 7 different greenhouse gas emissions within the Kyoto Protocol. This is very important. But we must absolutely be aware that if we just start with CO2e, then when will we bring in the other important aspects such as loss of biodiversity and human health impact? My understanding is that it took 20 years to create the quality adjusted life year. We don't have 20 years to wait to bring in greenhouse gas emissions as a unit of measure, and then 10 years later to bring in human health impact as a measure, and 10 years later after that to bring in loss of biodiversity. We have advanced life cycle assessment software we can start using now. My colleagues in the UK, surgeons, consultants who are using the advanced life cycle assessment software now to produce very nice peer-reviewed publications in this space, we can look to them to start to utilize these models to be able to provide a much more comprehensive and holistic output that makes more sense for HTAi.
Thank you. If there's anybody in the room who wants to stand up for one question, I think that's also possible, but I don't see anybody else. Yes, Ogi. We take one question from the floor.
I'm very sorry, I haven't used my voice this morning. So what if we turn the question a little bit around? What if the reduction is reducing the disease burden and using HTAi actually to become much more effective now I'm talking about low and middle income countries. So really going in and saying, don't copy bad practices from the so-called advanced countries and really pushing that way. How do you see that?
Yeah, thank you very much for that question. Part of this, I am going back to my favorite framework because it's a really good example, so I'm sorry for using it again, but the Centre for Sustainable Healthcare in Oxford in the UK, the priorities in the prevention space, so health technologies which are able to prevent disease, public health intervention, keeping people healthy, absolutely this needs to be priority if we're going to look at a more sustainable development approach to HTA. If we keep people healthy, we keep people out of healthcare, we keep people away from the need for use in healthcare resources. It's a no-brainer, right? So we really need to try to focus on prioritizing and maximizing the impact of HTA, which is in the prevention space. So health technologies, if they can become a priority within the HTA's priority criteria, then certainly if we can support our HTA colleagues across the broader stakeholder group as well, to look to evaluate more in the prevention space, this is where we should focus. Thank you.
Thank you, Melissa. I think in corners of time, I think you did a very well job of
you,
defending yourself. So I hope you will get a good score at the end of the meeting. And I would like to ask probably to the next panelist to come up.
Well, welcome, Shitanshu. Excellent first round. Please don't forget to answer the poll regarding environmental sustainability, because it will go away shortly. To the next.
Okay. Good morning, everyone. So in my medical school, they told me that before you expose yourself, you should be comfortable. So now I am very comfortable. Thank you so much, Melissa, for that lovely pitch that you did for environmental sustainability. Now it's my turn to talk about the adaptive HTA. So I'm going to talk about the role of adaptive HTA in decision making. I am Sitanshu. I come from India, the southern part of India, and I work as professor of preventive and social medicine there in JIPMER, Jawaharlal Institute of Postgraduate Medical Education and Research. As you have seen that we have 3 slides given to us saying that we should focus on that. So 6 years work in 3 slides. Thank you so much for your generosity. So we are going to talk about need, the rigor, and implementability of adaptive HTA. So why adaptive HTA is coming into frame? Because many countries have started to go in that aspirational path of universal health coverage. So when we talk about universal health coverage, there are a lot of interventions, and a lot of interventions should come into the health benefit package so that the government is going to fund them and people are going to have access to it without with reducing in the financial hardship for them. So when we're talking about universal health coverage, how do we then find out which interventions are going to come into the package? So there is a systematic process, a multidisciplinary process where HTA comes into picture, and we try to look at the various interventions which have got value for money, which we should include, which we should not include. But that HTA process is sometimes the full or traditional HTA is time consuming, it takes time, and also requires a lot of technical capacity. So institutions or countries where the ecosystem is just developing, it takes time for identifying and doing it the proper way. So is there any other way of doing that? So can adaptive HTA play a role in that? So there are many terms that are used for adaptive HTA, rapid, mini, rapid reviews, and many other names. The basic difference between these two things are the de novo modeling exercise from the local data. So we'll talk about that a little later, and we'll see if we can see that adaptive HTA can be a type of methods to do something when the full HTA ecosystem has not developed yet. Sorry for this busy slide, but that's because of them. I could not have helped it. When you try to differentiate between full HTA and adaptive HTA, what is the difference? The first point is timeline. So if you look at timeline, the full HTA takes time, depending upon the capacity of the institution, between 9 months to 2 years. But if you look at adaptive HTA, it can be done faster, between 1 to 6 months, depending upon the methods that you adapt. What are the analysis that we look forward there? So in full HTA, the classical thing is the de novo clinical and economic evaluation modeling that is done. But in adaptive HTA, we try to see the model that has been developed elsewhere, can that be adapted to our setting, and can we take some decision? So next is data sourcing, local studies in full HTA with primary data collection, systematic literature review, but in adaptive HTA, it is from the HTA reports, targeted literature search. The benefits are all mentioned there, the adjustment to the health benefit package, the price negotiation, and all other things are written there. Adaptive HTA more or less helps to go there, but sometimes people don't trust it so much. We'll talk about that a little later. So when we are doing the same process, taking the evidence from one particular country and trying to adapt it in our setting, then there are certain issues that come to our mind. The first one is transferability issue, the contextual factor. Does it really seem to be same? The health system is similar or different? So based on that, there are some limitations there. So when we talk about the scientific rigor, if the studies are coming from large-scale RCTs, probably it will, and the intervention is very simplified one. It can be used for adaptive HTA. Studies, RCTs with less sample size, probably we should not take it into adaptive HTA for decision making. Local data, the need of local data, because context is very important. What we need to do is, if local data are not available, then adaptive HTA sometimes becomes difficult, but that is what we have at our hand. We do not have local data. How do we take decision? So it is better to take decision based on some analysis from somewhere rather than doing it on a blank sheet of paper. Timing of decision, if we think that the duration or the time availability is less, so probably adaptive HTA will help in that direction. As we all know, because we work with policymakers, the deadline is always yesterday, right? The question is asked today, but the deadline is yesterday. So we have to find time for doing that. The last one is, when there is high budget impact, probably adaptive HTA is not going to help, because people will ask question, because taxpayers' money are going into the health benefit package. The last part of our discussion is implementability. How do we do it? So I'll tell you, there are no standard method of adaptive HTA. As of now, people are in different stages of developing it. Many countries have done it. In India, we also do it, but we do it for topic prioritization. We do not take it for health benefit package inclusion, so to exclude topics to be part of our health benefit package. But when there is the budget impact or the budget to be allocated, we prefer the full HTA to be done at this point of time. Because of contextual significance and transferability issues, the important thing is we should have an institutionalization mechanism. It should be written in that the HTA framework that we have, that adaptive HTA can be used for decision making. So that's a very important component there. Stakeholder engagement, trust, like any other point, that is very, very important there. And standardized adaptation methods. So these are all in the stage of evolvement, and we try to go from one step to the other. So slowly we'll try to see if adaptive HTA in the next meeting can have some more scientific rigor and some more uses for the countries that we are trying to work now. I think this is my last slide. But to summarize, if you look at the triggers for adaptive HTA would be urgency, certainty of evidence is available, and low budget impact. Adaptive HTA is another tool in our HTA ecosystem. It is not a replacement of full traditional HTA, but I'd like to summarize or end my topic with this Japanese proverb, which is known as wabi shabi. We have to find beauty in the imperfect world. As HTA researcher or methodologist, we all work in imperfect. When the data is not ready, data imperfect, methods are imperfect, but we have to take some analysis and take it there and present it to the policymakers. With that, I stop, and as this is my first time in HTAi, I expect him to be little soft for me. Thank you.
Well, thank you, Sitanshu. I think that we have to challenge you a little bit. And I think there will be questions from the floor. One question I have, which is fundamental, I think you talk about full HTA and adaptive HTA as it are two different categories. My kind of thinking would any HTA is actually adaptive. And it really depends on how you actually organize it. So the HTA could be like very full or somewhere in between, and now you seem to actually identify two categories of HTA. Would it not be better to just name the beast and say, well, we do a full HTA, we do a rapid review, and don't get all this fuss about adaptive HTA?
Yeah, thank you, Wim, for that wonderful question. Actually, that's a very, very pertinent question to the discussion that we are having. Any HTA, we do adapt because we take information from various parts of the country and try to develop a model. But in the full HTA or the traditional HTA, the component that we do very well is the de novo modeling or effectiveness analysis. So that part is very crucial because when we take with the local data that are available, so that the contextual factor taken into consideration, the health system perspective are also part of it, and we develop our ICER value or a summary estimate, and we can also do the sensitivity analysis to see the robustness of the model. But in this type of analysis, what we are proposing now, or what is being advocated now, is basically you take the models from somewhere else and try to see if it works in your setting. So that is the basic difference to my mind, that though in adaptive HTA, we completely depend upon the models from the other countries or the reports from other countries, what is coming, in full HTA, we try to develop our own de novo models and try to get the answer to it. So that's probably the basic difference between these two. Thank you.
Thank you. So one question which comes up from the floor, and I think it's a very specific question, but maybe interesting, is how adaptive HTA in India is aligned with health prioritization?
So, see, I can give you the example from my country, India, how do we do it? 3 years ago, when we started working on adaptive HTA, the committee, the HTAi, said, no, we don't want to look at that. So it is evolving. Slowly, we are trying to go there. What we do right now is, because there is a topic prioritization committee, when all the questions that we receive from the user departments, the HTAi center looks at those questions very carefully, and which question should be taken as for full HTA or to be consideration for the analysis is done by adaptive HTA. So what we do, we look at the information that is available from various agencies, various reports, and also do targeted literature search to find out the answer for those questions, and then take it there. At this point of time, another analysis what we did in our place is we found that the cost factor shows a lot of variability, but the health outcome or the QALYs that is calculated or the clinical effectiveness is more or less aligns to what other countries are telling. So the difference is how do you adjust for this cost factor in the whole analysis. At this point of time, adaptive HTA in India, we do it for topic selection and exclusion of topics so that we don't invest a lot of time in the full HTA. And that's what we do as of now.
I see a number of questions coming from the audience which seem to think that the adaptive HTA has a big focus on cost effectiveness. We do not think that just a broader approach, also taking other elements into account, makes sense for an adaptive HTA. So that all kind of things which have to do with, for instance, also the liberation, that would be important. I think now it seems a bit like an adaptive HTA is just a kind of adaptation of an economic model, and it might be more.
Yeah. So to answer to that question, probably to my mind will be, it depends what is we are dealing with. So if we are dealing with simple intervention, like a specific drug or a medical device, or maybe an intervention which can be classified as simple enough, based on the country's context, can be taken into adaptive HTA for decision making. But when you are looking at screening strategy, large complex health interventions to be a part of your health benefit package, adaptive HTA still has not got that traction as of now. So that's my thinking, that what we can do now at this point of time is to have a type of validation of the full HTA and adaptive HTA, and we see how much the ICER value is differing from each other, and try to generate some evidence base, and based on that, we take this concept forward. In some European countries, we have got some checklist type of things available in Central and Eastern European countries, where people give individual checklist and give weightage to each of the marks that they get. Below threshold, they accept; above threshold, they reject. So, but that improves transparency. But I'm not sure, because we have not used it as of now for decision making.
You just come to a topic which is also, I think, important for me. We know that also in Central and Eastern European countries, I think there have been methods like scorecards and checking lists being used. And I think that kind of thinking was, well, we look at European reports, we do a small adaptation, and that's our adaptive HTA. But we have a lot of questions about the quality and the relevance of this kind of adaptive HTAs. So what would be your suggestion to actually avoid that there is a kind of thinking, well, adaptive HTA is easy and is not very well methodologically developed?
Yeah, so I'll again repeat what I told in my presentation. Adaptive HTA is a toolbox that is available in our HTA framework. Depending upon the context, depending upon the questions that we are trying to answer, we should use it or we should not use it. It is exactly that point of time. If we are confident and if we are trying to see that the evidence that is coming from another setting is quite similar to us, probably yes, but it has to be decided by a group of people within the country, and in that context, we have to take it forward.
So one quick question from the room. Anybody who would like to say? Yes, please. Oh, this one.
Good morning. I'm an information specialist, so in my point of view, we work with rapid reviews a lot also, but I think we don't need more bad reviews, we need more good reviews, and we have a lot of bad reviews. To any topic you can think of, there's a lot of amount of bad reviews. We need just one good review, and not from India, from other countries, and so what do you say about that? How we could just collaborate and make one good review, because if it's like that, like you said, you have large RCTs and you know the evidence, then it's really easy, right?
Yes.
So I could do you a good review in a small amount of time, because if it's the evidence base like that.
Yeah, but the question is, what is good is considered to be good, and what is, so the best thing that what we can do is, when we do reviews are done based on the information that is available, or another person who has done a study about that. So I completely agree with that point, that we can collaborate and try to develop a particular review which is robust and which is good. But again, the contextual factor will also play a role. The health system, the way that it responds to the treatment mechanism that is available, it also plays a role. So it's a little complex at this point of time. So my suggestion would be, that it has to be country specific. It has to be done at your own HTAi ecosystem at this point of time. How do we take it from there? So I'll stop at that point of time. Probably we are also learning about these methods. So once we are trying to get into this particular thing next time, probably we'll be more wiser.
Well, thank you, Sitanju. I think also this was an excellent defense. So I hope you get a lot of votes. And I would like to go to the last presenter, Cyril.
Thank you so much. Thank you.
And a reminder to reminder to please place your votes too in the polling. Thank you, Sitanju. Great job. Tough questions for a first timer.
Good morning, everyone. I hope you can all hear me. So the title of this presentation is pretty deliberate, provocative maybe. I think we've reached a point where traditional HTAi processes, which are linear, which are retrospective, time-consuming, and costly, as it's been discussed, are no longer fit for today's world, where complexity and speed have become the norm. So this presentation is not going to be about replacing judgment with AI, not at all, but really using AI and real-world data to shift HTAi from those linear and static processes to something that could be more dynamic and system-wide learning. Let's briefly anchor the discussion into the basics and the fundamentals. You all know that very well. On the left part, I've listed the objectives, what we're trying to achieve, really. And basically what we're trying to do is to combine clinical, economic, ethical, and societal dimensions. And then the methods that we're using and the many stakeholders. But on the right part of the slide, you'll see what is at stake. What are those issues that we're facing? And we're really facing faster innovation cycles, tighter budgets throughout the world. I speak from Africa, but it's the same thing in Europe or in the Americas or Asia. It's everywhere. We're all facing those issues. And public demand for access and transparency. So HTAi is basically pulled into many directions. And the question is there a way for us to leverage those new tools? And that's what I'm going to try to answer. So why now, basically? The need. Because we have both the need and the means. On the left part, I have the various elements that are triggering the usage of RWE and AI. And then, it's not only that we must, it's also an opportunity to reinvent ourselves. So the pace of innovation, especially in personalized medicine, is exploding. And RCTs are costly. They're the best, obviously, but they're costly and they're not built for this space. So real-world evidence and AI give us the tools to adapt faster without embedding rigor. Really, I want to stress that. It's not about doing like easy subpar assessments. It's about making more sense out of the data we have in ways we couldn't imagine before. So the opportunity here is not just more data, it's smarter, faster, more inclusive evidence generation. And there are many, many examples. I mean, look at what happened during COVID in many countries, but I'll just pick Israel, the UK. We had like live real-world dashboards that were extremely useful. There is also the great example of in oncology in the US with Flatiron that basically pulls together EHR data and then helps build more evidence. Now, the next question is rigor. Well, maybe we're not fully there, but we're getting there, and we're getting there very quickly. So the algorithms that we have right now, they're super powerful, but they're not magic. What we have are tools that, if they're well designed, validated, and transparently reported, generally outperforms traditional methods in handling the reality, which is complex data sets, messy data sets, and very heterogeneous data. And with the traditional methods, we're failing short, or we're saying, well, we can't do it. So let's explore what we could do. And once again, we're not fully there. I don't want to feel like I'm in a cattle show or a livestock competition and I want good grades. I'm telling you, this could be the way, and let's work towards it. Of course, there are caveats. We need interoperability, and that's one of the big topics that I'm working on for Africa. We need bias controls, and bias controls mean actually more data. Just to give you a simple example, I come from a Francophone country, and we know that more than 70% of the data on internet is in English. Just this is a very, very big bias. So it's about digitizing, and making sure there is more data available. And then it's about harmonization. And those issues are not solved yet, but we're all in various circles working towards that. On the right part, I mentioned HTAi and Lime. I mean, beyond the hype, I think those approaches are extremely important because they're really about making sure that the types of black boxes that we're sometimes facing when it comes to AI are translated into more simple descriptions that we can understand. Very often for the common layman, and I would put myself definitely in there, although this is my field, it's difficult to understand what is happening with some of the AI models. So those tools, those approaches will increase explainability and will make sure that there is more transparency, because in the end, that's what we want. We want trust, and trust means to be able to be transparent, which is not really the case for everyone and all the models. So the use of AI in retrospective oncology, for instance, improves treatment pathways, and I mean, there are a few specific examples where we can definitely say that the rigor is there. There are a few others where we need to continue the efforts. And overall, it's really about making sure that we work on those few elements for harmonization, bias control, interpretability, sorry. Implementability now. So that's the big question. What can we do now? What can we actually do out of this? So the answer is that we're already working with those tools. Once again, Flatiron Run in oncology, but in Germany, there is the DIGA fast track for digital health applications. In France, where I'm based, we also have the forfait innovation, which helps fast track or use some of the AI approaches for specific use cases. What we're really missing is scale, coordination, and capacity. We need interoperable infrastructure, analytical talents, and updated ethical frameworks. Yeah, I think that's how I'd like to close this. Really, my presentation is really about saying that AI is not a threat. It's not about replacing what we do well. It's just an opportunity to challenge the inertia and to build stronger systems that will be, more efficient or more adapted to the new reality that we're all in. The technologies are here. The risks are real, but so is the opportunity. So the question is, who will lead this transformation? And I think we should work together for that.
So thank you, Cyril, for this very optimistic view on using AI in healthcare. I would like to challenge this a little bit. And I think that we currently, and I'm working for an HTAi organization, I think AI is being used, and we see it, and I think it's a kind of hype sometimes that the files we get, well, we have real-world evidence in AI. I think you refer to it, but sometimes we feel it's just a way to mask up sloppy data. So we get sloppy data, and we get reference to AI, and that's what we have to use if we make an assessment, for instance, of a new pharmaceutical. What are we really there? And another question is, what can we do to avoid that it has been seen? Because you refer, for instance, to flat iron, and I'm also aware of flat iron data. I've seen those data, and for many HTAi bodies, including mine, this is not enough, and we need better data. So what's your approach to that?
So first of all, Wim, this is a critical question, and it's a fair question. And I started saying we're not there yet. That being said, the question of quality data is critical, and I mentioned that. It's really about making sure that we have more data, that we digitize more, that we have clearer processes for data governance, for data security, for data privacy, making sure that we also have the transparency that is needed. So I really don't think that AI is there to replace anything. It's about really bringing more rigor when we are stuck. So it's more, it's not instead of.
Thank you. So another question I have, I'm also looking to the questions from the floor, is that a lot of the AI algorithms which we currently see, and I think it was also brought up in other panels earlier yesterday, are being generated by tech companies from the United States. And I think that they might have not a very close link to our solidarity-based healthcare systems, for instance, in Europe. So what can we do to ensure that what we get also includes the right algorithms and really also ensures that the data are supporting how we would like to continue with our healthcare systems, for instance, in Europe, but many other countries would like to have universal health coverage?
Yeah, fair question as well. I think it's just a clear proof that we need governments in control, or governments playing a stronger role with the other stakeholders, defining the rules of the games, making sure that there are ethical rules, that there are transparency rules, once again, privacy and clear ways of handling data. We don't have the same ideologies on different parts of the world. I won't say what I prefer, but I do live in Europe. And really, it's about investing into the capacity within the governments or the agencies. It's about recruiting new types of jobs and positions, and making sure that we help shape those discussions and not follow the big companies. It's about political leadership, definitely. And data sets, are not open by definitions. So there are rules that we have to define for those large companies from different parts of the world to work with our data sets or not. Basically, it's about governance, and we're slowly getting there. Yeah.
So a little bit more technical question from the floor. We heard a lot about generative AI, about large language models. While initially, I think we were more using NLP kind of models, for instance, for systematic reviews. So how reliable are those new forms of AI, like generative AI? Can we use large language models in HTAi?
Well, in my presentation, I did mention natural language processing, but I think big data, and if I may go back, no, I cannot. I think the hype with ChatGPT is not everything that is going on here. There are many other efforts that are being made. Overall, and I'm not sure this is the answer to this question, but it would be a summary of what I think. The needs for strong infrastructures and capacity are important throughout the sectors in our governments. And there is no way we should do that in a siloed way. We need to strengthen, but also make sure that we have a whole of government approach. You can see that I speak as a policy advisor and not as an academic. Then we need to help shape the innovation, also through the HTAi processes and the various processes that we will accept that use AI, so that we can guide the innovation. That will be my answer.
Thank you, Cyril. I think there is room for one question from the room, and I think already somebody there. So sorry, Cliff.
Sorry, Cliff.
But then there is coffee afterwards.
Yeah.
So just one question. Thanks very much for the interesting panel. I think we can see that some of the common themes throughout the conference are AI and environmental sustainability. I think at the same time, it's an open secret that AI has some rather large environmental impacts.
Yeah.
And so I wonder if the panel could comment on how, as an HTAi organizations or producers, we might reconcile those two competing objectives.
Yeah, that's a hard one. It's a very fair question. Yes, a simple question that you ask to ChatGPT consumes so much water and energy, etc. We're very well aware of that. It doesn't mean that we shouldn't be exploring the best ways to leverage those tools. Once again, it's not destiny, it's not fate, it's a tool. And we need to find the proper and relevant use cases where it works. And if the impact, earlier we spoke about DALIs and QALIs on human health, are, balanced with the costs, I think it's fair. I have no specific answer. We need to look at each and every situation. And in order to do that, we need to bring everyone around the table, the many stakeholders that I listed on my first slide.
I think Melissa also wants to respond to this, isn't it?
Thank you for the question, Laura. We're lacking environmental data at the moment in terms of AI intrinsic characteristics that generate environmental impact. There's a huge amount of water used as well as energy to house energy centres for AI, and we have a very finite amount of water left to use on the planet. That's really one significant environmental aspect that we need to be considering. I think I'm just going back to when Bogie was asking the question before about preventative space and keeping people healthy and disease prevention. That's really where we need to keep going back to, is that focus on that, and that's really spearheading that opportunity to keep people healthy. Early diagnosis using AI, great, especially if these particular health technologies are, people can receive them in their own home and they don't need to enter healthcare facilities. So there's lots of different things to weigh up in terms of what are the benefits of AI in terms of how the AI technology fulfills the criteria of a sustainable quality improvement framework. Does it create a leaner care pathway? Does it really stop resource use in terms of single-use fossil fuel devices? How does the AI influence the care pathway in terms of reducing environmental impact downstream? So I would want to know all of those things and then measure that up with the product life cycle assessment of the AI itself. So the functional unit, we call it the functional unit. So for that device is used by one person for that particular indication, you would then produce a carbon footprint or whatever other type of environmental assessment you do for the AI product first, and then compare it to the care pathway environmental assessment to make that decision. Thanks.
Thank you, Melissa. Thank you, Cyril. And again, I hope that everybody will vote, because I think I give the floor back to the moderators.
Excellent. Well, really 3 hard rounds we had. Hope you all voted, and now the polls will be shown in somewhere. We have to give Amren some seconds to do the final analysis. And we count 4, 3, 2, 1. And let's see. Okay, well, first we have to note that the axes that do not start in 0, no? So the difference looks big here. But if you see, we have a 6.5 for sustainability, 6.8 for adaptive HTAi, and the winner is AI and RWE with 6.9. We don't have the confidence intervals and the p-values, but they were really close, no? So thank you for participating. I hope you enjoyed the session, and I pass the mic to Marina.
All right, and just remember too, we had Q&A, and I think if we looked at the number of questions according to the Q&A, we might see the opposite trend. So keep that in mind too for all of our panelists, that I think the audience is really looking for examples of where there's been success, but also challenges. So thanks for sharing your thoughts. And a big thank you to the audience as well for your participation.